Mitral
Yes, sir.
regurgitation.
Pointer is also coming.
These are my
Yes,
disclosures.
disclosure. Yes.
Now it's good.
If we talk about mitral regurgitation, you need several informations. You need to have the information on the valve anatomy. You need to have information on the mitral regurgitation etiology. That's the most important thing of all. Is it primary or is it secondary? Primary is the prolapses. It's a valvular disease. Secondary, it's the ventricle. If the ventricle dilates, your mitral valve doesn't close anymore, and you get mitral regurgitation. This is the secondary disease. The secondary disease is what we see mostly in the daily practice. MR severity, how do we quantify? You've seen all these very fancy approaches, but in the practice, they do not really work. We need to know about the annulus and the subvalvular apparatus. What about the annulus if it's heavily calcified? What about the subvalvular apparatus if it's too dilated? We need to talk about LV function. That information is key, probably the most key. LV function determines the prognosis of those patients. We need to know about LV size and LV shape. Okay, let's talk very simple, mitral valve anatomy. If we talk about mitral valve anatomy, we need to know that there is leaflets, there is an annulus, there are chordae, there are papillary muscles, and the most important of all this is the left ventricle. All this here is number 1 to 4 is the disease of the valve. But this one is the disease of the ventricle. And that is, in the Western world as we are, the most significant cause of mitral regurgitation. It's not a disease of the valve. It's the ventricle that gets dilated and you get secondary mitral regurgitation. Here you see the valve anatomy. We got two parts. An anterior part, which is split in A1, A2, A3. We got a posterior part, which is split in P1, P2, P3. These are the commissures here at both ends. We started as first in the world working with CT. We did the CT for the coronaries, and in the early, I think 2000s, we saw that in addition to coronary arteries, you could also see other things. You could see the right ventricle, and you could see the left ventricle, and in the left ventricle, we could see the mitral valve, much better than we ever did with echo. This is anatomical imaging, it's not functional imaging. If we image the anatomy, the best way to do it is a CT scan. If you image the function, the best way to do it is 2D echo, or nowadays 3D echo. Next step, MR etiology, primary or is it secondary? This is a valvular problem. This is a transesophageal. Here's the atrium. This is the right side of the heart with the tricuspid valve. And this is the left ventricle. You see here, this part is prolapsing, very easily to pick up. And the jet goes always away from the prolapsing part. So this is the prolapsing part, and the jet goes that direction. So MR etiology, excessive motion of the leaflets, P2, primary MR. This is a degenerative disease. It's a prolapsing disease. It's a problem of the valve. It's not a problem of the ventricle. This is what we see mostly now in the Western worlds. MR etiology secondary to LV remodeling. I have 1, 2, 3, 4 infarctions in this heart. Eventually, you end up with this dilated, non-functioning heart. What happens when this heart dilates is that the leaflets of the mitral valve get retracted into the ventricle. Once they don't close here in the normal plane, but get retracted, they close only a very little bit or not at all. And then you get, in general, a central mitral regurgitation. This is secondary MR. This is not a problem of the valve. This is a problem starting with ischemic or non-ischemic dilated cardiomyopathy. And then it becomes a problem of the valve. So it starts very different than the other one, problem of the ventricle. MR severity, how do we get there? So we have what you learned previously, the vena contracta, but I don't use it because the vena contracta you measure here. This is the ventricle, this is the atrium, there goes the jet, right? And you can also see it on a transthoracic here. What happens is that we measure this part here. So the vena contracta is the jet area as it leaves the effective regurgent orifice area. This is it. If you measure it and I measure it, we will for sure have two different numbers. I say 7, you say 5. What is important is that the resolution of the echo machine has 5 and 7 but doesn't have 6. So if we start to do academic and we say, this is 6.3, that's nonsense because your resolution simply doesn't allow this. That's why I do not believe much in vena contracta. This comes from the clinical floor, not from studies and research. This is the daily practice. The systolic pulmonary flow reversal is a good one. If the jet goes all the way into the atrium, then the pulmonary that normally comes in, the pulmonary flow that fills the atrium, is no longer able to enter because all this jet is coming back and pushing back what you see here, and you get the systolic pulmonary flow reversal. This one I do not recommend. This one I think is a good one. Then we come to the mitral regurgitation quantification. This is the famous PISA, proximal isovelocity surface area. This is built up first measuring the effective regurgent orifice area, which is in a simple word, the leaking hole. So we use for that 2πr squared. The r is the first radiate that you see here, the velocity aliasing, times velocity aliasing divided by the velocity max. Now this one is an easy one to get. This one, if I make a small mistake of 1 millimeter, it changes completely the severity. So we can measure effective regurgent orifice area or regurgitant volume. I use these ones. But you need to remember, because these ones are easy to get, but you need to remember every eccentric jet, I cannot get this because I don't have a vertical flow. It will go like this. When do we have an eccentric jet? At the prolapses. So a lot of these things work very well in secondary MR, but not in primary MR. We also have worked a lot with this here. This is really beautiful, but it's not practical in the daily practice. I'm sorry, I want to show you this one. So we use MRI, and we put a scout over the valves. We put the scout over the mitral valve and over the tricuspid valve here, but we're not looking at the tricuspid today. Then we get these different views. And from these different views, we can tease out completely the flow over the mitral valve and the tricuspid valve, mitral valve and tricuspid. And if we take out now just the flow over the mitral valve, I'm going to get this curve here. And that gives me exactly the forward flow, the backward flow, and from that we calculate the regurgitant ejection fraction, regurgitant fraction. So that gives you absolutely quantified how much blood is leaking from the mitral valve. The point is, if you have done an MRI yourself, I've done it myself, you lay in there for about half an hour, maybe more, 45 minutes. It's very claustrophobic. And if most of these people present with heart failure, they cannot lay flat in the MR. So the MRI is not a good tool. So where are we? I don't know. I think simple measures. We can also measure annulus and calcifications. That we do with CT. And this is very important for transcatheter procedures. How much calcium is there in the leaflets? Then the most important thing is LV size, shape, and function. We can do that with everything. Echo, MRI, CT. Less patients present with primary MR. It's a disease of the valve and most undergo surgery. But most patients have secondary MR, and this is a disease of the ventricle. Now we come to the discussion of the mitral clip, because a lot of people like to use the mitral clip. It's a simple procedure. Mitral clip is certainly in secondary MR a good option, but we have two studies here. This is the French study where mitral FR, all these patients had the clip. The blue ones are the controls. The red ones are the ones that got the clip. And you see that the outcome is exactly the same, which is not good. At 12 months, about 50% of these patients had an event, mostly mortality. This is the co-op study from Greg Stone, published in the same year. And he showed that if I give a device, which is a mitral clip, the outcome is significantly better than if I do just optimized medical therapy. So we have two studies. This one says it doesn't matter what I do, and this one says it's great if you put the mitral clip. Well, let's go to the clinics. Observation number one. Without treatment, there is a huge mortality. So without treatment, secondary MR, a disease of the ventricle mostly, if you let it go, just medical, the patient, half of them will die within short. Observation two. One trial is very positive. The other trial is completely negative. So why is this? How do I bring it together? Oh, let me check. This is the work from Greg Stone. All hospitalizations, heart failure within 36 months. These are the patients that got medical therapy over a follow-up of 36 months. And these are the patients that got a mitral clip. And look at the huge difference. It's a huge success. The number needed to treat was only 3.2 if you look at 24 months follow-up. The number needed to treat was sustained if you look at 36 months follow-up. Here it was 3, here it was 3.2. Look at the p-value. I cannot even count these numbers. If we look at all-cause mortality, it's the same story. This is the mitral clip, and this is medical therapy alone. Big difference. Number needed to treat is 7 with a p-value of this. Why is this one trial very positive and why is the other trial completely negative? I've been thinking about that long time, and finally I think we found the answer. I'm going to give you two examples. This is a 79-year-old male, ischemic cardiomyopathy, admitted with acute heart failure 3 times in the last year. High cholesterol, smoker, renal failure, coronary disease, 3 vessels, cannot be revascularized, ECG, AFib, they mostly have all AFib, right bundle branch block. This is the medication, enalapril, furosemide, metoprolol, dabigatran, and atorvastatin. And you're going to say, well, this is not optimized medical therapy. But in the daily practice, a lot of these patients don't tolerate all these medications. If you look in your own practice, it's hard to get these patients on all these medications because it has a lot of side effects. This is the MRI of the patient. We see a dilated ventricle, and there is scar in the lateral wall. That's an old infarction. Here I see the echo. This is where the scar is. It's not moving. The atria enlarged. We learned about in the previous talk about the tricuspid. The same goes for the mitral. Is it in severe AFib? You sometimes see very, very big atria, then this starts to dilate and there comes a regurgitation. We're not talking about that here. We're only talking about ventricular disease. So this is a regurgitation here. LV EDD is 60, end diastolic dimension. End diastolic volume is 170, end systolic volume 150. The EF is 32%. The effective regurgitant orifice area, which is nothing different than the leaking hole here, is 37, and the volume is 50. This, I'm going to call for you when you see the second one. This is a relatively small LV with a large MR. The disease is more mitral regurgitation than ventricular. We did 2 mitral clip implantations. Patient in New York Class 1, no more admissions, heart failure medication downgraded, and you see here the result. LV EDD 60, LV EDV 161, ESV 116, ejection fraction 28. This is a really bad case. This is a 74-year-old man, non-ischemic cardiomyopathy, has VTs in 1995, gets an ICD, has chronic AFib, they all have that, as I said before. 2000, his bundle ablation and CRTD, is in New York class 4. You get amiodarone, digoxin, bumetanide, losartan, and warfarin. LVEDD is huge as compared to the previous patient. This is a big, big ventricle. LVEDD is 80, and diastolic volume is 500, and systolic volume is 400. The ejection fraction is 21. Effective regurgitant orifice area is 19, and the regurgitant volume is 23. This is a big ventricle with a relatively small MR. We did what we could. We did a mitral clip implantation. Patient ended in New York class 4. He died at 9 months follow-up. We have the 6 months follow-up. LVEDD is 80, LV diastolic volume is 450, and systolic volume is 400. The ejection fraction is 11%. It's a good success in terms of taking away the mitral regurgitation, but my ejection fraction came down completely. Why are these two patients different? Patient 1 has an LVEDD of 60, has an EDV of 170 and an ESV of 115 and an EF of 32%. It has a regurgitant orifice area of 37. I call this the leaking hole. It has a regurgitant volume, leaking amount of blood, of 50. I would call this a relatively small LV with a large MR. Look at this one versus that one. This is the second patient, the patient with an EDD of 80, an end-diastolic volume of 500, a systolic volume of 400, and an EF of 21%. This leaking hole is small, and the volume is only 23. This is a large ventricle with a relatively small MR. This is a ventricular disease. If I'm going to clip that, then I take away that mitral regurgitation that there is. But what happens is that this big ventricle can no longer handle to pump the blood forward. The way to let it go backwards was an escape for him to survive. If I take away that mitral regurgitation, then what happens is that he has to pump all the blood forward, and it shows really how bad the EF is. This is a mitral valve disease, and this is a ventricular disease. If you bring that all together, here is the mitral FR patients. They had an end diastolic volume of 250. These are the coapt patients. They had an end diastolic volume of 170. This is a small heart, and this is a big heart. This big heart has a relatively smaller effective regurgitant orifice area, which indicates that there is not so much mitral regurgitation as in these ones, where there is a big leaking hole and there is more mitral regurgitation. This one is more a ventricular disease. This one is more a valvular disease. How do we solve that now in daily practice? We take the strain. If you take the strain of the left ventricle, and let's say that it is below 12-13%, you should not clip the mitral valve or not do it surgically, because we've seen these cases also surgically, and if you repair them perfectly, the ventricle shows now really how bad the ejection fraction truly is. Because we had one case like that, where the ventricle was not doing more than this. So we repaired it. We did a perfect repair. It was a secondary MR, perfect repair. And when the patient had to come off pump, he couldn't get off pump, because this heart had an ejection fraction that looked reasonable, but half of it was going in the atrium that was not contributing to the ejection fraction. If I now close the back door, then he has to pump all that forward, and it shows immediately how bad the ventricle is. And what is the solution for that? The solution for that is very simple. It's just measure the strain, because the strain of the ventricle gives you really the force, what is in this ventricle. And if you have a severe MR and the strain is really, really low, you should not go for surgery and you should not do mitral clips. This is more MR in the coapt, and this is a smaller LV. So the coapt patients had more a mitral regurgitation disease and a relatively smaller disease and a relatively smaller ventricle. So these patients had a better substrate. If I take away that MR, this ventricle can pick up the work. And this was the mitral FR again, less MR and a large LV. This is a burned out ventricle. If I close the back door, I kill the ventricle and he cannot pump forward. I hope that I made it clear. It was a complex situation. We've been thinking endlessly about this. And then finally, when we published this for the first time, everybody said, yeah, that is it.
Thank you very much.
Thank you very much.
It was really outstanding talk and eye-opening. So, any questions?
Jerome, thank you very much. As Professor Tipu said, it was really an outstanding talk. And when you talked of the MITRA FR trial and the COAP trial, what we can understand is that it was the difference in the left ventricular function and the left ventricular size. Because if you have a small MR and a large LV, there is an equalization of the pressures both in the left ventricle and the left atrium early on. And if you treat the mitral regurgitation, small as it may be, there is an added load onto the left ventricle. The ejection fraction goes down further, and therefore these patients did not improve. Is that the right way to understand it?
That is absolutely it. That is absolutely it. And what you're saying there goes also for the tricuspid regurgitation. It's exactly the same problem on the right side. If your ventricular function is gone, you should not clip, because you're really killing the patient, because that patient is living on that right ventricle thanks to the fact that he has unloading through the tricuspid. So there is this whole hype at the moment that we can do all sorts of treatments of tricuspid regurgitation. But I say, be very careful what you do, because we've seen also cases with that. When you close the tricuspid valve completely, you blow up the right ventricle, because the ventricle doesn't have the power left, because the ejection fraction, same story as on the left side, the ejection fraction is calculated by the blood that leaves the ventricle, and it doesn't matter if it goes through the back door or to the front door. Now, 85% of the patients that we see is secondary TR, the same as the mitral. It's a disease of the right ventricle, and the right ventricle doesn't have an isolated disease. This is heart failure with coronary artery disease or dilated cardiomyopathies. That starts on the left side, then spreads to the right side. Your RV starts to dilate, and then you get a TR. The RV dilates because the function goes down. That's the final common pathway of what we see in coronary artery disease. If you wait long enough with the patients, they all end with RV problems. So if you then close the TR on the right side, then you blow up the right ventricle. Same story as on the left side. We've seen those cases also. So as soon as it becomes secondary MR or secondary TR, secondary to coronary artery disease, which in the Western world is about 85% of your patients, if you close those back doors, you really kill the patient.